professor in medicine and gastroenterology in Christian Albrecht University and Klinikum Schleswig-Holstein in Kiel, Germany. Welcome. He's going to talk about the complications of immunomodulator and biological treatment.
Thank you very much for the invitation. I'm honored to be here, and I'm very much impressed by the conference already from what I've seen. I have now the task to talk about complications of therapy. And as you can imagine, with infective therapy, there are many. I'd like to start with a presentation. It's a 32-year-old patient born in Croatia, migrated to Germany 10 years ago. Since 3 years, Crohn's disease chronically active. Despite of extended exposure to prednisone, they are up to 10 diarrheas per day and up to 1/3 with blood. There's no significant previous disease, no significant family history. The patient is married, 2 children, works at home, no nicotine, no alcohol consumption. She's in good health otherwise. There's abdominal tenderness, in particular in the right lower quadrant. All other organs, no pathologic findings. Her hemoglobin is low. She certainly has an iron deficiency. She has inflammation. This is the assessment. You see obviously intense inflammation here in sonography, including intense perfusion. You see the inflammation of the colon. You see the histology, which also gives you a significant amount of inflammation in this case. So the patient has Crohn's disease with significant chronic activity and steroid-dependent course. There's indication for immunosuppressive therapy. The patient receives azathioprine anti-TNF. Before therapy, there has been a negative PPD test, a negative hepatitis A, B, C, and HIV screening, a normal chest X-ray, and of course an abscess has been excluded in the abdomen by ultrasound. Start of medication, there's significant reduction of diarrhea and other symptoms within 6 weeks. There's normalization of laboratory abnormalities. However, the patient develops after 3 months a dry cough. 1 week of antibiotic therapy through family practitioner with cephalosporin, which was already retrospectively as a mistake instead of sending the patient. No night sweat, no weight loss, no B symptoms. Abdominal symptoms are still improving, still normal CRP. That's a chest X-ray 3 months after start. As you see the infiltrate here, so the patient now has pulmonary disease. The PPD test is repeated. It's again negative. Remember, the patient is on azathioprine and anti-TNF. There's one enlarged lymph node in the neck which is taken out because also differential diagnosis of lymphoma has been brought up. And as you see, the histology here shows acid-fast bacilli. So the patient has, with a negative PPD test at start, a negative PPD test under therapy, developed tuberculosis. There is no open tuberculosis. The patient receives a full treatment with 4 agents for 4 months, and then afterwards the treatment is INH and rifampicin for a few more months. However, 2 months after reduction of antibodies, the patient has again a dry cough. You see the infiltrate now here. And now the patient has open tuberculosis, detection of acid-fast bacilli in the sputum and stomach juice. The therapy is increased with addition of ethambutol and pyrazinamide. There's induction of severe drug exanthema through the ethambutol. The patient is then changed obviously to an alternative regimen here, which finally then clears the tuberculosis. So finally, the patient is obviously off therapy for IBD. She's clinically improved. Her abdominal symptoms are greatly improved, 3 to 5 loose stools per day, no cough, a significant reduction, and finally healing of the infiltrate in the chest X-ray. So I think this is a conclusion to be aware of. Tuberculosis development can be seen despite of negative PPD test. Maybe it's the influence of the prednisone therapy before. And obviously, in every lymph node swelling under immunosuppressive therapy, tuberculosis is a differential diagnosis. With that, I'd like to go into the details of what to expect. Best analyzed is the experience with Infliximab, because most patients in the world have received Infliximab much more than for other agents. And the Infliximab experience has been also published and worked up. We do not know that kind of data in such detail for the other anti-TNFs. So you'll see a lot of Infliximab data, but most of what I show you also applies to the other anti-TNF agents. And as you see here, there's a considerable number of more than 500,000 patients with Crohn's disease under therapy worldwide, and more than 700,000 patients with RA. Together, it's in the analyses that are out here, as state February 2012, more than 1.6 million people treated. So tuberculosis, to start with that. Tuberculosis, we are all unaware that tuberculosis would play a role, increased tuberculosis would play a role in anti-TNF therapy until the year 2000. And you see here the reporting came in, and since then, obviously, reports have been done every year. However, with the availability and the consequence of screening, be it PPD screening or quantiferon gold assay, you see that the number of tuberculosis has come down. So the screening out of patients and the treating of patients who do have a positive test, I think, has helped a lot to control the problem, but it's still not completely controlled, as you see also in that example which I've shown you. The risk of tuberculosis appears to be dependent on the agent you use. It is much higher, obviously, in Adalimumab and Infliximab than in etanercept treatment. Here you see all anti-TNF treatment. Here you see as a reference the general French population. The next problem is serious infections. There's a whole number of serious infections one can get, and I've put here again the infections that have been reported worldwide on this map. Pneumocystis, histoplasmosis, candida mucosis, listeriosis, cytomegaloly, atypical mycobacteria, aspergillosis, cryptococcus, salmonellosis, others, and herpes are the main groups. There has been a registry, the so-called TREAT registry, which has been used to follow Crohn's disease patients for 5 years. It's a registry that has been sponsored by the manufacturer of Infliximab, but I think it can be considered an independent observation. The registry compares the effects of Infliximab treatment, prednisone treatment, and also looks at the effects of narcotic analgesics. And here you see the latest readout of that registry, which I think is interesting. It shows you an increase, as expected, for patients being treated on Infliximab, and tendentially even bigger increase for the chronic use of prednisone, then obviously the heavy use of narcotic analgesics, and remember this is a US-based registry where this is probably more done than in Europe, is a larger risk factor, and the largest risk factor is untreated severe and fulminant disease activity. I think this highlights the dilemma in which we are in. Of course, we are introducing here agents that can cause and promote infections, but untreated disease or just covering symptoms is even a worse choice. Here in a different readout, again, the most recent reporting of the infectious complications. You see the leader here is herpes, and then there's Candida, cytomegalovirus, atypical mycobacterial infection, and pneumocystis, which usually only occurs if you do multimodal immunosuppressive therapy and you probably overdo what you're doing with this patient. I like to point out that there is no single point when you can be safe that the patient will not acquire any infection. This is the 10-year observations through Adalimumab, and it shows you just the rate of infection coming in down to here, year 9, and you see there's a linear curve. So if the patient has done well for 1 or 2 or 3 years in your practice, and he or she comes back with either some night sweats, some unspecific symptoms, maybe some coughing, you should be alert. Even if the patient has been so many years under therapy without complications, the risk every year is the same that the patient may acquire some complication. And I think the most important lesson is to treat fast, to admit the patient, not to send the patient away. In a general cough situation, you can say you come back on Monday if the patient shows up on Friday with some fever, and we see whether your cough improves. However, if this is a patient under immunosuppression, especially under anti-TNF, you should investigate that patient and even admit him or her to the hospital if you can clear this up. Another challenge is hepatitis B virus. Hepatitis B virus can be reactivated under anti-TNF therapy. It should be treated if it's present before you initiate anti-TNF therapy. And as you see, there's a reporting rate of about 1 to 2 cases per 100,000 that comes in every year in an unchanged way, and therefore the hepatitis B diagnosis is an integral part before you start with an anti-TNF therapy. Patients are even more concerned about malignancies. And there is a relationship between anti-TNF and malignancy, and I think this is highlighted by this trial here. In the early days of Infliximab, there was an idea that maybe Infliximab could cure end-stage chronic obstructive pulmonary disease. These are patients in our world who are smoking heavily, in many, many cases also drinking heavily, and the life expectancy of such patients is usually between 6 and 12 months, so it's a very severe and complicated population that comes in here. In this population, you see very frequently head and neck cancer, or you see esophageal and stomach cancer. And very often these patients, if you find one cancer, then get a second one. So these patients with a history of heavy smoking got Infliximab, and what you saw is that 5 out of 157 patients treated with Infliximab developed carcinoma, whereas only 1 of 77 treated with placebo. So again, in that population, carcinoma is probably pre-existing. But I think it shows us that if there's pre-existing carcinoma, that will grow faster and become overt much faster if you treat with Infliximab. So there is a relationship between Infliximab and carcinoma. This experience has led us to precautions. For example, if a patient has a history of breast cancer or colonic cancer, we would hesitate a lot to introduce anti-TNF therapy because we do know that remaining cancer now has a risk of coming back or growing faster. The most 5 common types of cancer that are observed under Infliximab treatment and Adalimumab treatment are skin neoplasms, miscellaneous unspecific neoplasms, breast cancer, gastrointestinal cancer, and respiratory cancer. It's important to notice that there is an increase, modest increase in many observations for the use of anti-TNF drugs. It's modest, but it's overall significant. And it shows you that there is a positive relationship between the use of these agents and the occurrence of cancer, especially cancer of the skin. However, one shouldn't forget that there are always concomitant medications in the game. And the SESAME study has observed more than 25,000 French patients with inflammatory bowel disease. And they have attempted to sort out what the effect of azathioprine, so thiopurine derivatives, and anti-TNFs is. And as you see here, you see increase of non-melanoma skin cancer in those patients who either are still continuing the azathioprine therapy or have discontinued, but certainly not in those who have never received azathioprine or its derivatives. Here are the numbers, and you see that there is a risk which is increased up to 5-fold under azathioprine therapy to develop such cancer. And so I think at the moment the question is out, what is the driver of that observation of increased cancer? Is it more the anti-TNF use, or may it be the high use and the long use of azathioprine and its derivatives? Lymphoma is a scare for patients because of its potentially deadly consequence. And as you see here, all kinds of different lymphomas are observed under anti-TNF treated patients, and they are also observed under all the different indications where anti-TNF is used. This is an analysis from a registry that has been conducted independently. It looks at lymphoma and anti-TNF treated patients, and again lines out that Adalimumab and Infliximab are associated with an increased lymphoma risk. And again the question comes up, what is a true driver? Is it the anti-TNF or is it the azathioprine and its derivatives? And again the SESAME study has been analyzed here, and you see again the same pattern. Continued azathioprine therapy or discontinued azathioprine therapy is giving you higher risk than lymphoma than if you have never had such therapy. And especially a risk are those patients above 65 years. Here again the numbers, and I think here you see the expected cases and the standardized incidence ratio, and I'd just like to point out the expected cases here 2.49, and then obviously observed 6.36 under continued thiopurine therapy. If you look at the effects of the anti-TNF therapy, then very often in combination with thiopurines, you see, of course, a similar increase, but this is not significant in contrast to the thiopurine therapy. Apart from such severe problems, our patients are also bothered by the hypersensitivity and fusion reactions they experience. Obviously, the major driver for infusion reactions is that anti-TNF agent that is infused, which is Infliximab, and you see here the number of infusion-related complications as compared to placebo, so there's a clear association with Infliximab. However, I like to point out that many of these infusion-related reactions are recovering with or without medical therapy, so either the administration of prednisone or just the slowing of the infusion helps over lots of these problems. A major confounder is a consequence with which you use Infliximab. I think it's important to point out that the Infliximab used under episodic therapy, so not in a programmed fashion, the same by the way with Adalimumab, is a much higher driver for antibody generation, and the presence of antibodies is associated with reactions to the drug. And then as an additional factor, with all due caution due to obviously the problems you can get through that, the introduction of thiopurine derivatives as additional immunosuppressants can bring down the incidence of antibodies and obviously help you to sustain the efficacy of anti-TNF and also bring down the number of infusions or injection reactions. Our patients very often come back with skin problems, and I've brought you a few pictures to highlight what can happen here. First, there's a systematic study looking at 85 consecutive patients with skin lesions. You see that there has been a considerable percentage of psoriatic skin lesions under anti-TNF, so not just eczema lesions. You see it affects all anti-TNFs, both Infliximab and Adalimumab, although Adalimumab in this study to a lesser extent, something I cannot confirm for my daily practice. For me it looks the same for both anti-TNF agents. A particular risk is a family risk history of inflammatory skin disease, and I'd like to point out this can be severe. In this study, 34% of patients had to discontinue anti-TNF treatment. The skin reactions can be allergic, it can be infections, it can be paradoxical, which are, for example, the psoriatic or vasculitis skin lesions, and obviously there are skin tumors, as you have seen before, which are an important differential diagnosis. So these are typical pictures from our practice. Urticaria or quincke edema are forming as a type of allergic reactions to anti-TNF, or exanthema. Here is this patient, the typical picture, but then also an exanthema picture which can be confused with vasculitis or even leading to substantial skin lesions. The occurrence of infections is seen frequently, be it as folliculitis, furunculosis, or even in the form of abscesses under anti-TNF. We do see a considerable number of viral skin infections, like this patient here with herpes, or this patient with varicella reactivation here. And the paradox skin reactions under anti-TNF therapy are particularly challenged because they often demand that you introduce a second immunosuppressant like prednisone or methotrexate or even cyclosporin A to control them. They are worsening in 20%, are pre-existing, or have a new onset in about 80% of patients. They are obviously those reactions that are non-infectious but inflammatory and occur under the therapy with anti-TNF. We term them immune-mediated skin lesions. These are typical examples of paradoxic skin lesions here, or this palmar psoriasis form, or here in the back of the patient. And these can be, as you see here, quite severe, and they definitely require the attention of a dermatologist. As you see here, they can be quite bothersome for the patient in the nose or leading to hair loss, and a final picture of more skin lesions that are associated and caused by anti-TNF itself. And the correct diagnosis, including biopsy, and the initiation of additional therapy here is key. The paradox skin lesions occur most often in RA, then in spondyloarthritis, and then in IBD, and finally in psoriasis. Female are more at risk, typically age 30 to 50. A family history of psoriasis is definitely a risk factor. There's no trend for any specific TNF antagonist. And these psoriasis-like skin lesions typically develop within 6 months of initiation of therapy. The more vasculitic skin lesions, then also later during therapy. Final point, mortality. Our patients don't like to die. That's the ultimate reason why they go to the doctor. This is the mortality curves of IBD. And as you see, we have come a long way before the anti-TNF therapy to improve the mortality of our patients. Before this, around the Second World War, as you see here, having IBD was almost a death sentence, with 70% of patients being dead after 10 years. And you see by now the introduction of 5-ASA, the consequent use of prednisone, the introduction of immunosuppressants, and the introduction of anti-TNF. There's still a certain mortality, which is about double that of the normal population, but it's obviously very well controlled. If we look into mortality of anti-TNFs, we interestingly enough find no signal. Here, very clearly, there's no increased mortality in this rheumatoid arthritis cohort for patients receiving Infliximab, etanercept, with or without methotrexate. And it's important, and this is the data from the Adalimumab development program, that anti-TNF, consequent use of anti-TNF, even decreases mortality. RA decreased mortality, psoriasis decreased mortality tendency, and spondylolytic arthritis and Crohn's disease. Why? Because patients obviously don't die of the disease and their complications, and most interestingly, it appears that there's decreased cardiovascular mortality, and this shows up particularly well in those populations that are elderly and have a higher death frequency and therefore give you more statistical power, like RA and spondyloarthritis. And this is a further analysis that highlights that factor. Here, the study looks at cardiovascular and on the right side, and all-cause mortality. And I'd like to point out the lower figure here. This is linked to the use of chronic use of prednisone. You see that high doses of prednisone obviously are a mortality factor that is quite significant. Here are the lower uses of prednisone and no use of prednisone. So after all, the prednisone use may be a cofactor driving mortality. Certainly, it is not the use of anti-TNF, which is rather preserving and improving mortality. That is also shown by the TREAT registry. Again, the 5-year registry on the use of Infliximab in Crohn's disease. You see that the increased mortality is mainly due to the use of corticosteroids and the use again of analgetics or uncontrolled disease. Here is the use of anti-TNF and the use of immunosuppressants, leading to no increased mortality. So let me conclude at that point. After that Prof through the side effects, the use of anti-TNF promotes increased infectious and malignant complications, and obviously tuberculosis is a very important one, even though the patient has no history and no family history of tuberculosis. And even a negative PPD test should make you aware that there may be keep you aware that there may be tuberculosis developing. The highest risk for infections is caused by multiple concomitant therapies in addition to the anti-TNF. You've seen the effect of azathioprine, you've seen the effect of prednisone. Uncontrolled disease is a considerable risk factor for infections and malignancies. And I think it's important to take home that early diagnosis and therapy of complications is the single most important activity one can have in the treatment of these patients. We, for example, have created for our immunosuppressive patients the same as we have our transplant patients. We have a service which is manned by the gastroenterologist, rheumatologist, liver people, and the dermatologist. And we make sure that always a person is on call to see patients that come on with complicated patients, and that can be then treated much quicker than if the patient first goes to a general internist. Thank you very much.
Thank you very much. Could you come please here for the panel discussion?
Thank you, Professor Scheriber. Before before we open the stage for the